هلا بالنسبة للأسئلة بالنسبة للامتحان يعني أخفف عليكم، رح يكون موضوع سهل إن شاء الله. هو 7 أسئلة pharmacology. 7 4 lectures 7 questions. لأنه امتحان 50 سؤال. So I'll be asking you more about يعني ممكن 4 to 3 anti-arrhythmic 3 ischemic heart disease. وركزوا على الأدوية، يعني إحنا للأسف لأنه ما بنشرح الباثوفيسيولوجي قبل الفارماكولوجي، we spend a lot of time explaining pathophysiology or the pathology، وطبعا ما بنعطيه حقه أبدا، بس عشان نقدر شوية. فأنتوا ركزوا على الأدوية واستعمالاتها، الميكانيزم of action, side effects, contraindications. محاضرتي اليوم بدي أمشي أسرع على الباثوفيسيولوجي لأنكم أخذتوا الإسكيميك هارت ديزيز بالباثولوجي، right؟ So
Contraindication.
So let's start, please. Angina pectoris. It's one form of ischemic heart disease. As you remember, or what Dr. Nisreen have told you, ischemic heart disease can be subdivided into 2 main groups. And then myocardial infarction is one, and the second whole angina. So today's explanation رح أشرحه أكثر عن the drugs that are helping us deal with the treatment of angina pectoris. Hello, what is angina pectoris? It's a sudden severe pressing chest pain. It can be radiating to the neck, jaw, back, and arm. The episodes are transient. They can stay between 15 seconds to 15 minutes. Now, what are we interested in is the cause, because if we know the cause, we know how we can modulate that cause in order for us to treat. So it is caused by a reduction in the coronary blood flow to the level that it does not meet the requirements of the myocardium. And this leads to what is called ischemia. So, the mechanism, if we talk about ischemic heart disease, it happens because we have an imbalance of the ratio between the oxygen supply and the oxygen demand. So if we modulate either one of these parameters, either the oxygen supply to increase, of course, the oxygen supply, or the oxygen demand, we want to decrease the oxygen demand. Very quickly, I want to review with you the types of angina, because we're going to be talking a little bit about which drug is used for which kind. حكينا ischemic heart disease are subdivided into either myocardial infarction or angina pectoris. Angina is subdivided into 2. One that has a predisposing cause, اللي هو is caused by obstruction. What kind of obstruction are we talking about? Atherosclerosis. So in atherosclerosis, the predisposing factor, one of the highest conditions that predispose for atherosclerosis اللي هو high LDL levels. What is the treatment for that? اللي هو drugs that lower LDL or lipid lowering drugs. And this will have a separate lecture on its own. So we're not going to be talking today about treatment of atherosclerosis. But atherosclerosis represents in signs and symptoms of angina. So what is this kind of angina? It's called typical angina. Typical angina يعني because it has, or it's called secondary angina, it has a predisposing cause. There's something causing it. So we can anticipate that the patient is going to have this kind of condition. When does it happen? When does it show? If I go ahead and run a marathon upon exercise, so somebody performs unusual effort, that's why it's called effort angina as well. So it is caused by atherosclerosis. It is happening upon exertion. It is subdivided into stable and unstable angina. Stable angina is the one we're going to be dealing with more. Unstable angina اللي هي dealing with regards to today's lecture. الunstable angina نقدر نعتبرها اللي هي between stable angina and myocardial infarction. Excellent. So drugs related to that اللي هم مثلا anticoagulants, lipid lowering drugs, we're not going to be explaining them today. You learned about anticoagulants already. We will explain lipid lowering drugs later on. The other kind اللي هو acute vasospasm. The acute vasospasm بنسميها variant angina. So it happened because we have constriction أو spasm of the vascular smooth muscle. شو الاسم الثاني إلها؟ Prinzmetal's angina or atypical angina. It has multiple names, but they all belong or they all explain the condition when we have pain because of sudden spasm, vasospasm, of course, of one of the coronary blood vessels. This table is showing us the major differences between the two main kinds of angina. So primary angina, it happens on its own. Again, it's caused by vasospasm. Another name for it is variant Prinzmetal atypical angina. It occurs at rest. It occurs usually in large vessels at usually one site, and it's characterized by vasospasm and some of the ECG changes that occurs with it causes ST elevation. The secondary kind, اللي هو secondary to atherosclerosis, is the classical kind. It's typical. It's called angina of effort. It occurs in small blood vessels, usually one or multiple blood vessels. لأنه ممكن هذا الأثيروسكلروسيس بصير مش ببلد فيسل واحد بأكثر من blood vessel. It's caused by atherosclerosis and it causes ST depression. Now, what will we be explaining? Today we want to explain the drugs that modulate the oxygen supply and the drugs that modulate the oxygen demand. So we have to have a balance between these two, oxygen demand and oxygen supply, in order to reduce the risk or the development of ischemia. So what are the factors that affect oxygen demand? If I have high heart rate, I'm going to need more oxygen. If I have high contractility, I'm going to need more oxygen. If I have high blood pressure, high afterload, the heart will need to work more against that high blood pressure. So I want to either modulate one of these mechanisms, the other one is preload. If I have too much blood reaching the heart, high preload, this also will increase the work of the heart. So inhibiting all of these four mechanisms will be beneficial for me to treat ischemia through reducing the oxygen demand. Now, which drugs do that? So you'll be talking about these groups. Beta-adrenergic antagonists. These work on the heart rate, the contractility. Some calcium channel blockers. The one we talked about last time, the ischemic heart disease lecture, which were they, زي verapamil and the diltiazem. We have organic nitrates, calcium channel blockers, and we're going to be talking about how these drugs, اللي هم vasodilators, will help in reduction of the preload and afterload, thus reducing the work of the heart. Now the other thing we said we can work on is oxygen supply. So we have drugs that increase the coronary blood flow. Again, these are the vasodilators, especially calcium channel blockers, in addition to the organic nitrates. And we have also drugs that have effects on the regional myocardial blood flow. So if we have atherosclerosis or if we have a block, if we have coagulation or thrombosis, we're going to talk about statins and antithrombotics. Statins, as we said, is going to be a separate lecture. Statins are a group of drugs that have a lipid lowering potential. So we're going to be explaining those drugs when we talk about atherosclerosis or drugs that modulate all the lipids of the body, not only LDL but other lipids as well.
دكتور المفروض انا ازيد الديماند كعلاج؟
لا بدي اقلل الديماند. ممتاز صح.
هسه عشان اقلل الديماند لازم الافتر لود والبري لود ايش اسوي فيه؟
نقللهم كمان. هلا اذا كان عندي high afterload, for example high blood pressure, the words have to pump more against that high afterload. إذا كان عندي high preload, so more blood is reaching to the heart, also the heart needs to work more to يعني يطلع هذا الامount of blood that reached it. So both of them, I'm going to lower them with the different treatment modalities we're going to talk about. So let's review الفسيولوجي تاع سنة تانية أو أولى. How do we control smooth muscle contraction? Remember this slide, probably you talked about it. We know that L-type calcium channel, once we have an action potential, this leads to opening of L-type calcium channel, this leads to entry of calcium into the vascular smooth muscle cell. ذكروا انها high vascular smooth muscle cell. Why is this important? Remember when we talked about the myocardium, also we have calcium entry there, but we have different kinds of receptors with regard to the adrenergic system, and this is this arm of the pathway. So I want you to remember always which kind of muscle or cell we are dealing with will have different effect even if we have the same signaling component inside the cell. يعني حتى لو عندي نفس cyclic AMP, it's going to have different effect in a cardiac myocyte than it would in vascular smooth muscle cell, for example. So let's go back here. Calcium enters the cell, it interacts with calmodulin, it forms calcium calmodulin complex. This causes activation of an enzyme called myosin light chain kinase. Myosin light chain kinase is a kinase, so what's it going to do? It's going to phosphorylate myosin. The phosphorylated myosin will intercalate with actin, causing muscle contraction. فبالتالي, when I block this, I'm going to prevent the contraction of the muscle leading to relaxation. Another pathway is called beta-2 agonist. Beta-2 agonists, if you remember, they are, present in the vascular smooth muscle cells, and what they do there is they cause relaxation. This is what I meant when I talked about the differential effect of the same receptor on different kind of cells or different tissues. So, in a muscle of the heart, a beta agonist will cause contraction. In the vascular smooth muscle cell, a beta agonist will cause relaxation. How does it do so? It's going to cause increase in cyclic AMP. This causes phosphorylation of myosin light chain kinase, which makes it inactive. So the inactive kinase will not be able to phosphorylate the myosin light chain. It will not be able to contract. It leads to relaxation. In addition to that, it can also cause activation of phosphatases that causes dephosphatation of this myosin light chain. بالتالي بيخففوا الactivity تاعتهم. في هنا another pathway that we mentioned later was cyclic JMP pathway, and this also is very important in vascular smooth muscle relaxation. So what are the different drugs that can affect the vascular smooth muscle contraction? Either they're going to cause contraction or they're going to cause relaxation. The first group of drugs is calcium channel blockers. This is the abbreviation for it, CCBs. So calcium influx is inhibited by calcium channel blocker, leading to muscle relaxation. اللي هو شرحنا قبل شوي. The other group of drugs, we have a group of drugs called organic nitrate. Organic nitrate اللي هم زي nitroglycerin. شو النيتروجليسرين بتعرفوا عنه؟ حبل اللي بنحط تحت اللسان. Excellent. So what does it release? What does it make? Nitric oxide. It simply releases a gas that is vasodilatory. It's a vasoactive gas. يعني هو إحدى أهم المسببات للvascular relaxation أو modulating vascular tone. It's controlled by this gas in addition to other neurotransmitters and peptides. And في عندي balance بين الvasoconstrictors والvasodilator. من أهم الvasodilators, one of the most important vasodilators that is present in our body, that is responsible for maintaining a normal vascular function, is nitric oxide. Once nitric oxide is released, it activates an enzyme called guanylyl cyclase. This increases the formation of cyclic GMP, which causes vascular smooth muscle relaxation through different mechanisms. One of these mechanisms is activated myosin phosphatases activity, which will decrease the active myosin level. So let's go for the next slide and look at the effects of organic nitrates. Organic nitrates, they release nitric oxide. Nitric oxide is a gas, it's a very short-lived gas, يعني it diffuses very quickly. عشان هيك لاحظ هذا النيتروجليسرين, the pill that you put sublingually, it has a very short onset of action. The onset of action of it starts within 2 to 5 minutes. This is because it's immediately releasing my substrates that will go directly into the cells and bind to its receptor, أو مش receptor بهاي الحالة, its target. The target of it, it's an intracellular enzyme called guanylyl cyclase that activates phosphatases to decrease myosin light chain kinase activity. بالتالي it will gonna decrease the contraction, hence we're gonna have relaxation. Now other things, we mentioned about adenyl cyclase, we talked about agonist, حكينا beta 1, beta 2 agonist. So this is the beta adrenoceptor. Here an agonist is epinephrine. Epinephrine is going to bind to the beta 2 agonist, increase cyclic AMP. We said cyclic AMP will cause myosin light chain kinase to be deactivated, hence causing also less contraction, less activation of myosin. The other pathway is the alpha 1 adrenergic receptor. So we have here an agonist for the alpha adrenergic receptor, who norepinephrine. Remember that adrenergic receptors are G protein coupled receptors, and we have different kinds of G protein coupled receptor. So the G protein coupled receptor to the alpha, the G protein coupled to the alpha receptor is a GQ G protein. And if you remember the pathway, it activates phosphatidyl. Yes, phospholipase C, thank you, to produce inositol triphosphate. Inositol triphosphate will do multiple effects, but one of the things it does, it causes increase in the sequestration of calcium from the endoplasmic reticulum. Thus, it's going to cause increase in the intracellular calcium level, leading to muscle contraction. So, this is summarized here. An alpha adrenoceptor agonist activates phospholipase C, which increases formation of inositol triphosphate from phosphatidyl inositol biphosphate, leading to increased release of calcium from the sarcoplasmic reticulum. So all of these different receptors regulate the vascular smooth muscle in order for it to give me the beneficial effect I need in ischemia. In ischemia, we do not really rely on alpha 1 receptor pathway. What do you think we should do to the alpha 1 receptor? Activate it or block it? Block it. If we block the alpha 1 receptor, we will cause relaxation, which will lower the blood pressure. We don't actually use a lot of alpha 1 antagonists to treat ischemia. They are drugs that are useful in the treatment of hypertension, and we will be discussing these in detail about hypertension. But because we have newer drugs that have less side effects, better effects on different hemodynamic properties, we'll explain them in the hypertension lecture. We use the newer drugs more than we do with the alpha antagonist. But yet, the alpha antagonist is a treatment option to cause vascular smooth muscle relaxation and treat hypertension, but they're not used in ischemic heart disease. Having said so, lowering the blood pressure is beneficial for the treatment of ischemic heart disease. Why do you think that? Why do you think lowering blood pressure excellent, decrease of the afterload. But we're going to talk about drugs that decrease the afterload that have other benefits in treating ischemic heart disease. And we'll start with the organic nitrates. Organic nitrates, حكينا, they are releasing nitric oxide, activating cyclic GMP, causing dephosphorylation of the myosin light chain, which lead to vascular smooth muscle relaxation. It is effective in the 3 types of angina pectoris. اللي هم which 3 types? Stable, unstable, and the variant angina. what are the members of this group? We have isosorbide dinitrate, isosorbide mononitrate. We're not going to mention erythriol tetranitrate, but we will focus on nitroglycerin اللي هو prototype. This drug was discovered a long time ago, about 140 years ago. Their mechanism of action, which is very important, is summarized in decreased coronary spasm or vasoconstriction and in increased perfusion of the myocardial by relaxing coronary artery. This is one thing they do, but this is not the main reason why we like to use them to treat angina. So, yes, they are vasodilators. They will cause vascular smooth muscle cell relaxation. This will help dilate coronary blood vessel, leading to more perfusion of blood to the cardiac muscle. But they're also going to affect the other blood vessels in our body. So what would they do? They're going to decrease. Excellent. And the preload. So they're going to decrease. They have arteriolar and venous effects. So this is again the summary of their action. So this is nitric oxide. And I don't know, I didn't put the slide in the first lecture, but there's something important I want you to know about nitric oxide. Nitric oxide is, yes, it is given as a drug in the form of nitroglycerin, but it's also produced naturally in our body. You talked about endothelial nitric oxide synthase. So it's very important that also drugs that modulate the synthesis of nitric oxide will also help relax vascular smooth muscle cells. And the substrate for ENOS, endothelial nitric oxide synthase, this is the enzyme that is present inside endothelial cell that synthesizes nitric oxide is arginine. Arginine is what? It's an amino acid. It's very important because we're going to talk about later on towards next lecture maybe some important new drug that can modulate this pathway.
دكتور انت كيف ناخذ الباثويز؟
أي pathways؟
هم الباثويز
أكيد. مين اللي سأل؟
الانترميديتس كمان.
الإيش؟
الانترميديتس كمان.
زي إيش يعني؟
مثلا هون GC GTP turns into cyclic GMP using GG.
يعني إنه nitric oxide رح يتفاعل مع enzyme called guanylyl cyclase to convert هذا GC guanylyl cyclase. So it's going to convert GTP to cyclic GMP. Yes, I want you to know that. I might not ask you about it, لأن I'll be more prone to ask you about drugs, but this is something we spend like half of the lecture talking about, so I want you to know that. هلا كل هاي السلايدز repetition. Why do I put different slides? لأنه كل slide مختلفة فيها something added. And this is something we're going to go back to هنا, some of the drug interaction with organic nitrates. شباب معلش. So this is already what we've talked about. We talked about cyclic GMP causing dephosphorylation of myosin light chain, causing myosin light chain to be less active. Let's say it's going to intercalate with actin, thus leading to relaxation. The prototype اللي هو nitroglycerin, حكينا it's been used for more than 140 years. It is a non-specific smooth muscle relaxant. While we have mentioned one of the effects of cyclic GMP on the myosin light chain, it has other effects that also lead to vascular smooth muscle relaxation. It has multiple effects on different ion channels as well. The actions are not antagonized by any known antagonists, so until now we don't have a drug that will bind to the guanylyl cyclase enzyme and prevent its action. How is this drug used? We talked about the onset of action. We said this drug is given, one form that it's given sublingually, so it's usually administered sublingually. Why is it administered sublingually? Do you remember? Excellent, first pass effect. So it's highly subjected to the first pass effect, and this happens by an enzyme called reductase enzyme in the liver that will break down the drug. So we have significant first-pass metabolism of nitroglycerin that occurs in the liver. That's why it's administered through a non-oral route, so either sublingually or transdermal route. So it's given as a patch or as an ointment. But also we have certain formulation that we were able to modulate. Yani we did certain coating for the nitroglycerin into a sustained release form, so it is available also orally. Yani it gets released slowly in a certain coating that does not make it accessible for fast degradation of the liver enzyme. What I want you to know from this slide, in a sublingual, they're very fast acting, so you start acting in 2 minutes, they start acting. The duration of them is also short, so it stays working for 25 minutes. So tell you, when do we use them? What's the indication of them? If a patient have a sudden anginal attack, he probably have those nitroglycerin pill, بيحط حبة تحت لسانه and it relieves that attack. What does it do? On hemodynamics, it causes two general things: arteriolar vasodilation and venous vasodilation. The arteriolar vasodilation is short-lived, and it stays for 5 to 10 minutes. It leads to decreased systemic blood pressure, so this leads to decrease in the afterload. Unfortunately, because of that, and they had a decrease in systemic peripheral resistance will result in reflex tachycardia. So this is one of the side effects, but it happens only initially and usually at high doses with the use of the drug. Later on, we have the venous dilation effect more persistent, so it is a more intense effect even with low doses, and it lasts for 30 minutes. So this results in decrease in the venous return preload, which will decrease in myocardial oxygen demand, MVO2. Yes.
شو استفدنا إذا نقصنا الأفتر لود بس بعد هيك زدنا
هذا هو one of the side effects of this drug. So it's very short-lived effect. Yes, sometimes it results in problems, especially if we take two drugs that affect this pathway, but usually it's a short effect to tolerance develop to this effect after continued use of this drug. So yeah, so it can pose a risk, and we have to be careful about that.
زي كأنه صار مخالف المنظمة.
بس هو it's very short-term effect. Beneficial effect of nitroglycerin will happen because of the venous strain, more intense, more evident.
الديفيز الكيلو الديفيز هي افترض معناها نسوي احنا ديفيز للانجكشن فاكشن او الديفيز لكارديال اوتبوت.
cardiac output بقل لما نقلل الورك اوف ذا هارت. يس. هلا لما انت تقلل البريلود الامount of blood will be decreased with contractility. If it's decreased, yes, the amount, ejection fraction might be still the same, but the amount is less. Okay. هلا when do we use it? As we said, it's used for the prompt relief of an angina attack precipitated by exercise or emotional stress. It's given in the form of a sublingual or spray form as a drug of choice. So sublingual ليش؟ لأنه it's very fast acting. Within 2 minutes it starts working. Another thing, why did we choose it as a sublingual? It's a highly vascularized area. فبسرعة بصير له it will be quickly absorbed to the systemic circulation. Now, what are the side effects of this agent? Any drug that causes vasodilation, if it causes vasodilation intracranially, vasodilation of the cranial blood vessels puts pressure على receptors موجودين in the wall, that present in the wall of the blood vessel, stretch receptor, which will causing pain. So this pressure on the stretch receptor in the wall of the blood vessel in the cranial cavity causes headache. Again, it causes hypertension and tachycardia, and we said this is the initial effect, and usually tolerance develops to this side effect. It can cause increase in the intraocular and intracranial pressure. It causes methemoglobinemia, and we said tolerance develops for this arteriolar effect اللي هو tachycardia and the hypertension. People when in the ammunition industry here, صناعة المتفجرات, they get subjected to nitroglycerin because it is one of the substrates that is used in that industry. So we have sometimes people, if they work for a period of time in that industry, later on they're going to show signs and symptoms of withdrawal to nitroglycerin. He rebound, hypertension sometimes. Other kinds, isosorbide mononitrate, it has better bioavailability and longer duration of action. It is not subjected to the hepatic breakdown. فملاحظ it can have a duration of action of up to 12 to 24 hours. Isosorbide dinitrate, sorry, we'll fix that to an I. It gets broken down in the body to 2 mononitrate, and again it will have the same effects where it's not broken down by the liver enzyme, so it can be given orally as a slow release form. Talk about this group as a general. All of the 3 agents are effective, but they differ in their onset and duration of action. We talked about the rapid relief of an ongoing attack that is precipitated by exercise or emotional stress. We use sublingual nitroglycerin as the drug of choice. What are the main effects of nitroglycerin? We talked about the dilation of the large vein resulting in pooling of the blood of the vein, which diminishes the preload and reduces the work of the heart. And this is the main rationale why we use organic nitrates for the treatment of ischemic disease. So it's not because of their ability to dilate the coronary blood vessel, is why they are preferred for treating ischemic heart disease. While they do so, yes, they do dilate coronary blood vessel, so this is the number 2 here, but the main therapeutic benefit of nitroglycerin is through diminishing preload, through decreasing venous retear, and this is by dilation of large veins.
معناتها احنا هون قللنا الدماغ.
قللنا
يعني الفينس
فينا
بقلل الدماغ.
Yes.
والارتريول بقلل او بيزيد السبلاي.
الكورونري artery dilation مش الارتريول مش السيستميك arteries. Okay. هلا هو both of them البريلود والafterload will be decreased. So both of them have benefits in ischemic heart disease, decreasing the afterload will preload. In addition to that, because they are vasodilatory, they're going to dilate coronary blood vessels, so they're going to increase the supply. So this is 3 ways to modulate ischemic heart disease. But the major pathway of the beneficial effect of organic nitrate in treating ischemic heart disease is by decreasing the work of the heart through their main effect, intense effect on preload through dilation of the venous blood vasculature. Okay. We talked about the time of to onset of action varies from 1 minute to 1 hour for the different kinds. We said that nitroglycerin has significant first-pass metabolism, so it's only administered. It's not only. We said we have another form. But so it is mainly administered sublingually or transdermally. And we talked about the adverse effect. So we're going to move through that slide. One other important thing I want to mention is drug interaction. Sildenafil or Viagra can interact with organic nitrates because what's the mechanism of action of sildenafil? Phosphodiesterase inhibitor, excellent. So it's going to prevent, so it's a PDE inhibitor, it's going to prevent the breakdown of cyclic GMP. So this will result in increased levels of cyclic GMP. So we have 2 drugs now that are causing increased cyclic GMP, اللي هم nitric oxide, or organic nitrates, and also sildenafil. So this will result sometimes in excessive vasodilation, excessive hypertension leading to a reflex tachycardia, that can be precipitating in heart attack in the patient or myocardial infarction. So what do? Usually either we don't advise the patient to perform such a combination, or at least we give an interval of at least 6 hours. Let me double check, 6 or 4, yeah, 6. So an interval of 6 hours between the two agents. يعني واحد أخذ nitroglycerin to wait 6 hours before he takes sildenafil, so we wouldn't worry about this dangerous hypertension leading to the reflex tachycardia, which can predispose an arrhythmia or a myocardial infarction. Now we said tolerance develops sometimes to these agents. Tolerance, that means the patient, after taking the medication for some period of time, he stopped responding to particular medication. And if you remember when we talked about pharmacodynamics lecture last year, we said one mechanism to decrease the tolerance formation, we fool the body in giving drug-free intervals. So, for example, for organic nitrates, we can stop the drug for 12 hours, 10 to 12 hours at night. This will help restore the sensitivity to the receptors of the drug.
ممكن بس هنا نشوف في الايفكت اكسس دايليشن او ايش مخاطر الاكسس دايليشن؟
هلا لما يصير في عندي كثير dilation يصير عندي hypertension بيعمل reflex tachycardia، فعندي أنا now excessive activation of this can predispose the activation of the heart, which can predispose to arrhythmia or myocardial infarction. And already I have a diseased heart that's not functioning properly. هذا التيبل أو مش مطلوب منكم at all يعني، بس هو فيه تلخيص لل short acting, long acting organic nitrates. بشكل عام yes.
دكتور اظن درسنا من فتره انه الانجينا lasts for less than 20 minutes.
Yes.
فالديوريشن اوف اكشن لما نعطي دواء بيكون مثلا for 8 hours بيكون prophylactically.
Yes هلا why do we give yes it's going to be given for prophylactic other attacks not to occur. هلا for the acute attack اللي هي حكينا yes for 15 seconds to 15 minutes, we said we're going to use the short acting one that has fast onset of action and short duration of action. But usually we have also maintenance therapy. In addition to organic nitrates, we have other drugs that can be given to patients who have history of ischemic heart disease. Okay? Next group of drugs is more beta-adrenergic blockers. So what are these drugs? They prevent the action of catecholamines, so they're going to be more effective during exertion. What do I mean by that? When I perform an exercise, we have more adrenaline pumping out in our body, so that means more catecholamines circulating. So if I use a drug that blocks these catecholamines, this effect will be more evident or more beneficial when I'm exercising because I have more of those agonists. What do? Of course, we remember their mechanism of action. They suppress the heart by blocking the beta-1 receptor, and they reduce the work of the heart by decreasing the cardiac output. Also, they have effects on lowering the blood pressure. So this will help reduce the frequency and the severity of the angina attack. So we don't give them during an acute condition of angina, no, we give nitroglycerin, but this is maintenance therapy that the patient is put on to decrease the incidence and the severity of angina attacks. Usually, we have cardioselective agents such as acebutolol, atenolol, and metoprolol. We prefer these, of course, to the non-selective drugs such as propranolol because of the contraindication of non-selective drugs. So let's go ahead and try to remember these. What are the contraindications for the use of beta-adrenergic blocking agents? Let's start with the indications. It's used mainly to treat stable and unstable angina, also used to treat myocardial infarction. And the contraindication, the first one is variant angina. Why is that? We noted that when we use beta blocker for certain kinds of transmetal angina, the symptoms actually worsen in these patients. Why is that? Sometimes some of the beta blockers have ISA, intrinsic sympathomimetic activity. So it might be due to these effects, is because of their intrinsic. Example of these drugs is pindolol, for example. Pindolol should not be used to treat variant angina at all because of its ISA or ischemic, intrinsic sympathomimetic activity. هلا مو كلهم لهم هاي الاكتيفيتي. Acebutolol also have ischemic, intrinsic ISA, intrinsic sympathomimetic activity. So all beta blockers are not used in variant angina. We don't know exactly the mechanism, but we have noted that they do increase or worsen or aggravate the condition. Vitaly, what is the indication for using a beta blocker? Only stable or unstable angina? نعم prophylactically mainly, yes, but يعني ممكن إذا واحد صار عنده an acute angina attack, yes, we treated it with nitroglycerin, we also give him beta blocker. It will help also stabilize the condition. So short-acting ones will also be beneficial even in acute attack. Contraindication very now known for us, bronchial asthma. Why is it contraindicated? Especially for the non-selective, because it's going to cause bronchoconstriction, because if I have a non-selective beta adrenergic agonist, it's going to block the beta 2 adrenergic receptor that's present in the bronchi. Shabab, please.
البين دول هل تسوي لك بيز كونستكشن يعني؟
Yes, ممكن نزيد activation of the alpha 1 adrenergic receptor ويعمل constriction لأنه عنده, because it has intrinsic activity. The other contraindication is bradycardia. If I have a patient who have bradycardia, sinus bradycardia, for example, and I give him a beta blocker, it's going to worsen the condition of bradycardia because we're going to lower the heart rate more. Variant. Yes. Yes.
البندولار ما استخدمها نهائي
Variant angina.
والباقي تستخدمهم
Well, acebutolol I wouldn't. I know acebutolol also have ISA. لا هلا كل البيتا blockers ما بنستعملهم للانجينا. هلا one explanation is the intrinsic activity, but studies have shown that it worsens. And they tried them, they started using them, and it worsens the condition. So they are contraindicated in variant angina. هلا explanation اللي هو some of them such as pendolol have this activity. Okay?
دكتورة البندولار استخدم الستيبل او انستيبل انجينا.
I wouldn't as well, no. So when do we use them? They're actually recommended as the initial therapy for all patients unless they are contraindicated. We use them to reduce the risk of death and the risk of myocardial infarction development in patients who had a prior myocardial infarction. In addition to that, they're going to improve the mortality in patients who have hypertension and heart failure. Why is that? We're going to talk about hypertension and heart failure, and we also will learn that beta blockers are drugs that are used to treat this condition. فإذا عندي مريض عنده all of these conditions together, it would be beneficial to give him one drug that treats these multiple conditions. Next group of agents اللي هم calcium channel blockers. How many minutes do we have?
شو من؟
عن جد؟
Yes.
كثير المحاضرة الثانية مشينا أكثر. صح؟ Okay, so we let's try to finish in these 2 minutes as much as we can. Calcium channel blockers, it makes sense why we use them, right? Because we're preventing the entry of calcium. Hello, what we learned a little bit in antiarrhythmic, there are 2 different kinds of calcium, 2 general groups of calcium channel blockers. One of them is called dihydropyridines, وهي أمثلة عليهم اللي هم ايزو isradipine, nifedipine, amlodipine, and then we have the non-dihydropyridines. The example are verapamil and diltiazem. One important difference between these 2 general groups is dihydropyridines, they have higher affinity for L-type calcium channels that are present in the vascular smooth muscle cells, so they are vasodilators. They work peripherally on the blood vessels. They prevent the calcium entry to the vascular smooth muscle cells. On the other hand, the non-dihydropyridine, they mainly work on cardiac cells. So both of these groups will be beneficial for me in the treatment of angina. Cardiac non-dihydropyridine, زي الفيراباميل والدلتيازيم, اللي we talked about them بالarrhythmia. So how they work? They inhibit the entrance of calcium into the cardiac and smooth muscle cells of the coronary arteries. So nifedipine causes arteriolar vasodilation, with less effect or minimal effect on the heart. Again, they are mainly working on the calcium channel in the vasculature. So they are useful in the treatment of angina that is caused by spontaneous coronary spasm because they're vasodilators, so variant angina. On the other hand, verapamil or diltiazem, they cause a slowing of the cardiac conduction directly. Thus, this will lead to decrease in the oxygen demand. We should not use these agents in a patient who have congestive heart failure because we're going to even lower the conduction more and more because it's going to also have negative inotropic effect, decrease the contractility on those patients. Another thing, they should not be used in addition to beta blockers because also beta blockers have negative inotropic effect. Also, they lower the conduction or decrease the conduction of the heart. Talibamil block, so they shouldn't be used in patients who have AV block as well.
دكتورة
Yes.
شو هو congestive heart failure؟
Congestive heart failure, like terminal stages of heart failure, it's characterized by congestion, suddenly edema surrounding the heart. So because the heart is failing and ejection fraction is below 35, we don't want to make it even worse. That's why we don't use drugs that are negative inotropic drugs for those kind of failure. Okay. So we'll stop here. And next time we have a few slides left that will be included in the exam, and we'll start with a new topic next time that's not going to be included. Antihypertensive agents.